Hello and welcome. Let's talk about cholecystectomy along with laparoscopic cholecystectomy. So, the types of cholecystectomy along with their indications. There is emergency cholecystectomy, elective cholecystectomy, and interval cholecystectomy. Emergency is done in case of perforated gallbladder, acute emphysematous cholecystitis, and acute calculous cholecystitis. Elective for chronic cholecystitis, cholithiasis, and interval is for 6 to 8 weeks after conservative treatment of acute cholecystitis and empyema of gallbladder. The indications of cholecystectomy as a whole. In case of gallstone, which is symptomatic, or cholecystitis acute or chronic, or calculous cholecystitis, empyema of the gallbladder, and mucocele of gallbladder. Now, approaches of cholecystectomy. It may be open approach or it may be modern laparoscopic approach. Open approach has right subcostal incision, right pyramidal incision, modified Kuchar's horizontal incision, and Mayer-Robson incision. So, how is a patient prepared for cholecystectomy? First of all, there is full blood count is given. Renal profile and liver function tests are done. Prothrombin time, chest X-ray, electrocardiogram for 45 years old are medically indicated if antibiotic prophylaxis, deep vein thrombosis prophylaxis, and informed consent is taken. So, what are the complications? These include infection and subphrenic abscess, bleeding from cystic artery and from liver bed, injury to common bile duct or hepatic duct, bile leak and biliary fistula formation, biliary stricture formation, injuries to colon, duodenum, and mesentery. Now, let's talk about laparoscopic cholecystectomy. So, what is laparoscopic cholecystectomy? This is an operative procedure in which removal of gallbladder is done by means of laparoscopic means without opening the abdominal cavity. Now, steps. The position is supine, head end up and right side up. Anesthesia is general. Pneumoperitoneum is established and the ports are made, and the neck of the gallbladder is retracted towards the right iliac fossa, exposing callus triangle. 60 dot is defined and gallbladder is separated from liver bed. The cystic duct and artery are clipped and divided, and then gallbladder is removed. Advantages. There is less operative pain, decrease in wound size, reduction in wound infection, dehiscence, bleeding, herniation, and nerve entrapment, decreased wound trauma, improved vision, better cosmesis, improved mobility, decreased heat loss, shorter hospital stay, earlier return of normal physiological life, and earlier resumption of normal activities. Now, disadvantages or limitations of laparoscopic cholecystectomy. There is reliance on remote vision and operating, loss of tactile feedback, dependence on hand-eye coordination, difficulty with hemostasis, reliance on new techniques, and extraction of large specimens is difficult in case of this operation. Now, poor operative problems. Difficult callus triangle, dense adhesion, bleeding, anomalies of cystic duct and cystic artery. Now, what are the relative contraindications? These include extensive previous upper abdominal surgery, portal hypertension, major cardiovascular disease, and respiratory disease. The ports of laparoscopic cholecystectomy. First is the 10 mm port in umbilicus to pass 10 mm of the telescope, 10 mm port in midline epigastrium as a walking channel, and 2 5 mm ports at midclavicular and anterolateral line in subcostal region. Port-related complications of lap cholecystectomy. These are injury to gut, injury to major blood vessels like inferior vena cava or abdominal aorta, infection and gangrene, settling of cancer cells in abdominal wall if there was a carcinoma of gallbladder, abdominal peritoneal adhesions may occur. Complications of laparoscopic cholecystectomy. These are abdominal, which includes injury to the common bile duct, duodenum, liver bed, and right hepatic artery. Hemorrhage, accidental ligation of common bile duct, retained stone in common bile duct or migration of stone in common bile duct, reaction in hemorrhage in liver bed, and residual abscess. General complications are pulmonary, respiratory collapse, consolidation, and pneumonia. Cardiac, myocardial infarction, cardiac arrest. Urinary retention, renal failure, and wound infection and postoperative pyrexia. Follow-up of a patient after cholecystectomy. Follow-up in the recovery room, ensuring airway, breathing, and circulation are satisfactory, monitoring of pain, watching for complications, monitoring of blood pressure, pulse and oxygen saturation. In first postoperative day, the follow-up includes pulse, temperature and BP chart, breathing type, level of consciousness, urine output, oxygen saturation and heart rate using pulse oximeter, checking and encouraging limb movements, skin color, tongue color for adequacy of oxygenation, tongue for hydration, cardiac monitor and others. End of the topic.